Bismillahirrahmanirrahim. Assalamu alaikum. I am Professor Saadia Khan from U.M.D.C Medical and Dental College, which is one of the most popular institutions in private institution in Faisalabad, which is known for being an exclusively female institution. And my special interest is both obstetrics and gynecology, and infertility as well. Today I am going to speak a very important topic, which is vaginal birth after cesarean section, and actually how serious are we taking it. That is the important thing, because as you all know that the cesarean section has been rising tremendously, and the incidence in the private sector is horrendous, and even in the general sector, because the people are really scared of medico-legal implications. There might be so many other factors which is leading to a remarkably tremendous increase in rate of cesarean sections. Now, how can we cut down this rate? That is by either decreasing the rate of primary cesarean sections, or we can go for a trial of labor, that is VBAC. So vaginal birth after a cesarean section can be tried for non-recurrent indications for a previous cesarean section. But the selection of such patient and management presents a lot of controversy, and it generates a lot of dilemma, and we are going to discuss it one by one. And because you know that in 1916 Cregnin once said that once a cesarean, always a cesarean, and for many years and years this was what was going on and on and on, and they continued to practice this. But in 1988 American College of Obstetricians and Gynecologists came forward and said that most people should, with previous one cesarean section for a non-recurrent condition, should be counseled for an attempt to have a normal delivery as well. Then in 1990, again the US Public Health Service proposed that the cesarean section rate should drop after a previous cesarean, and the VBAC rate should rise to around 35%, and this was carried out. Again, there was a swing of pendulum in 1991. And then there was a lot of controversy which began, and the VBAC rates were around 28.3%, and the cesarean section rates were 20%. Then there was a paradigm shift on cesarean sections. Unfortunately, that evidence came in 2006 that VBACs might not be very safe. And suddenly there was a sharp decline in giving a trial of labor in a patient with previous cesarean sections. So this, why? Because there was a lot of fear was generated because of medico-legal implications, and the people started suing, and the obstetricians thought that to do obstetrics is really a nerve-wracking problem. And then they also, the clinicians thought that this is going to be very critical for the mother, with risk of increasing incidence of rupture of uterus and then neonatal implications as well. And at that time the rate of VBAC fell to 8.5%. Then came in 2017 came again, there was a regenerating and a rekindling of interest in previous cesarean sections. In that, there was an updated bulletin from the American College of Obs and Gynae, and then they said that at least 60 to 80% of the people with previous cesarean sections can undergo successful vaginal birth. So the best circumstances for the successful vaginal birth occur when we balance the risk factors and we balance the chances of success, and which are both acceptable to both the patient and the physician, which is different in every case. And there's certain conditions which are less likely if TOLAC is a word which is used in literature, which is the trial of labor after cesarean section is attempted. So what are those? These 4 critical points were emphasized by American College, and they are advanced maternal age. And sometimes we don't take this into consideration. Like the other day I had a patient, she was nearly 40, 39, and she came in labor. She had a previous cesarean section by myself 7 years ago, and she was 4 centimeters, very well effaced, strong contractions. But then I suddenly remembered this update, and I said no, because she has conceived after such a long time. And then I ran for a cesarean section, and it was good because there was a lot of meconium, there was cord around the neck, and the head was very low. So these recommendations are actually which we must keep on repeating with our PGs and our doctors, because then they should not go to the back of our minds. If it is we keep repeating these things, then they are really helpful. So apart from age, this high BMI is again very bad predictor for a normal vaginal birth. Even if the patient didn't have a previous cesarean section, you all know that in an obese patient, the risk of vaginal delivery may be reduced. So previous cesarean section that resulted due to dystocia, that is, there was failure to progress due to cervical dilatation did not take place after a long labor, then don't try them. And of course, high vaginal birth. If the birth weight is around 4 kilograms, don't go for a trial of labor. Then this American College, I've already discussed that there was a rekindling of interest, and then they emphasized that the risks which can be avoided due to this VBAC is the hazards of major abdominal surgery, and it also lowers the risk of hemorrhage, blood clots, infections, and it also shortens the recovery period. Obviously, after a normal delivery, the patient goes home very happy, nice, and healthy, and it reduces the woman's risk of experiencing morbidity and mortality. And during a future pregnancy also, because of a repeat cesarean section, and also the risk of placenta previa, accreta, and creta is reduced. And of course, a very important point is that we all know that after cesarean births, the neonatal respiratory complications are much more as compared to a vaginal delivery. So let's take a quick look at the predictors of vaginal birth after cesarean section and their success and failures. So the increased chances of success are actually seen when there is prior vaginal delivery. So that is really a good predictor for that. For example, first normal vaginal delivery, then second due to breech presentation, then a previous VBAC success. Obviously, after a successful previous VBAC, if you have lots of VBACs, obviously the uterus is going to become thinner, and the risk of uterine rupture increases, but this is a good thing. And then the patient should come into spontaneous labor. We are not going to induce or augment labor in a patient with previous cesarean section. If the person comes in labor and there is a favorable cervix, this is a good predictor sign. For example, that is 4 centimeters on admission. And then of course there is a previous non-recurrent occurring conditions like breech presentation, placenta previa, or herpes, or things like that. And if there is a preterm delivery, there are more chances of having a success. And a very important thing is epidural analgesia. So epidural analgesia is not a contraindication in patients undergoing VBAC, because the scar tenderness is not masked by an epidural anesthesia. This is a misconception in the minds of many people. So then the decreased chances of success are seen. Then we are some of the things we are going to repeat, like maternal obesity and a short maternal stature. There's an increased maternal age. I have already discussed that. Greater than 40 is obviously macrosomia. Induction of labor should not be carried out, in my opinion, at all. So recurrent conditions, like if there is previous cephalopelvic disproportion, failed second stage, in previous cesarean section done at full dilatation, And then there is an increased interpregnancy weight gain. That is again very important because it's a poor prognostic sign. Then Latino or African American race or ethnicity, gestational age more than 41 weeks, again a poor predictor, and preconceptional or gestational diabetes mellitus, as we all know, it causes lots of hazards are associated with it, and less than 2 years from previous cesarean section. This is very important. This is a question. Very often we have a patient coming to us just for the second delivery because now they think that they would be able to accomplish a normal delivery because they just blame the previous doctor that she has done an inadvertent cesarean section. Right out the outset, I tell them, look here, your baby is only 6 months old. I would not plan a VBAC for you at all. So if you want to go back to your previous doctor, you can go back. We are not going to try it. And this interpregnancy interval is counted from the date a patient is expected date of delivery in this pregnancy from the date of previous cesarean section. Then what are the contraindications? The contraindications are that we should not at all think about a VBAC if there is a previous uterine rupture or there is a previous high vertical classical cesarean section, and especially when the whole of the anterior surface of uterus is involved. Still these days such things are done occasionally, like for a patient with patient had a has a large lower segment fibroid which necessitated a classical cesarean section. In these patients, trial should not be given at all. And 3 or more previous cesarean sections, or if there is a prior inverted T-shaped NCN or a J-shaped NCN, the risk is remarkably increased. As you know that sometimes in transverse lie, you're stuck in a very bad way in a patient with a patient of neglected transverse lie, then you have to resort to a J-shape. Then you must write in your notes that you had to perform a J-shaped NCN or a T-shaped NCN. So again, another risk factor is prior vertical lower segments NCN. Now, what are the predictors of uterine rupture? You all know that uterine rupture is an extremely dreaded complication in obstetrics, and the risks again, this is a repetition, classical hysterectomy, 2 or more cesarean deliveries, and single layer closure. And we know that at one time there was a vogue, it came into fashion and the journals were full of it, you must go for a single closure only. And the people who quickly follow these, fortunately I was the one person who just performed 1 cesarean section with a single layer closure. And very soon, within few months, the literature started pouring in, maybe once or maybe in a year's time, that the risk of rupture of uterus increased. This was the Western data. Obviously, now this catgut is obsolete. We must tell our doctors working in the periphery, and now the cost of catgut and Vicryl is the same. So catgut is obsolete. The strength is not proper with catgut. So we should use a Vicryl. Obviously all of you are using Vicryl, I'm sure, and it should be in 2 layers and not 1 layer. And then induction of labor to be avoided. Don't use prostaglandins, oxytocin, don't augment labor if it is going spontaneously, fair enough, and a short interpregnancy interval, and infection if it occurs at a previous cesarean section, during previous cesarean section, this may hamper the integrity of your scar. Then there is a decreased risk of uterine rupture after spontaneous labor, as these are actually the same factors we have discussed previously, but this is just to reiterate. And then there is a prior vaginal delivery, and there is a longer interpregnancy interval in the preterm delivery. Now, a VBAC should only be attempted in a fully equipped hospital, fully staffed, and a delivery suite should be prepared in such a way, and the hospital should be such that there are facilities for carrying out an emergency cesarean section at any moment. Otherwise, if you are not in a fully equipped hospital, you should not take the patient or entertain the patient in that setup. Why? Because any time your trial of labor may result, may necessitate an emergency cesarean section. So continuous care should be provided during intrapartum and during and postpartum period as well. Sometimes people do develop a rupture of uterus which goes totally neglected and might be detected in the postpartum period after a baby has been even delivered. So all the available resources for immediate emergency care should be available. And obviously, when we say that all the resources we need, we want an expert obstetrician, we can't do without midwives' help, staff nurses, anesthetists, operating theatre, neonatal and hematological support. You may need a blood transfusion, so they should be continuously available. And the success rate is much higher if epidural analgesia is available. And continuous electronic monitoring must be provided, because an abnormal cardiotocograph is the most consistent finding in uterine rupture, and it is present in 55 to 87% of these events. Once I remember that there was a patient with previous cesarean, and the house staff was just doing, there were subtle decelerations, and unfortunately the girl conventionally just gave oxygen, turned her position right, then left, and there was a delay of 1 hour, and then patient had a ruptured uterus. So you must concentrate on cardiotocographic evaluations. Then we must provide continuous support, as we have already discussed. There is no single pathognomonic pointer towards rupture of uterus, as you know. Sometimes the rupture of uterus may occur very unexpectedly, and it is a catastrophic event, because now this baby is definitely not, we won't be able to save, or is going to develop hypoxic ischemic encephalopathy, and the mother is also going to suffer a lot of morbidity. Fortunately, mortality is reduced in birth centers, but neonatal outcome is compromised. So abnormal CTG, and we must take a notice of severe abdominal pain which any patient experiences, especially if it persists between contractions. Then chest pain or shoulder tip pain. Why? Because if there is a small amount of blood is leaking into the peritoneal cavity, it is going to irritate your diaphragm, and we must take a notice. Sudden onset of shortness of breath we should take a notice. And then acute onset scar tenderness is very important. And then if there is an abnormal vaginal bleeding, or there is a hematuria, we must think that something bad is happening. As you all know that when the patient is fully dilated, then the head is coming down and patient is under epidural, very often we see hematuria. But still we should be vigilant, on guard for looking for all the signs and symptoms of rupture of uterus. And the cesarean, and as you know that if there is cessation of previously efficient contractions, if suddenly the contractions stop, you must be most worried. And this is very important pointer which the house staff frequently misses. If the patient suddenly has loss of contraction, we should be really, really worried. So maternal tachycardia, hypotension or shock, these are obviously, when they develop, everybody detects them, but we should aim to detect it beforehand. And the loss, there is suddenly, once I remember I was in UK, and then we were attending a meeting, that suddenly the staff nurse came running. She said that the clip for internal cardiac monitoring was applied, and then she said that suddenly the scalp electrode has gone right up into it has disappeared. And what happened, and I can't feel the fetal head at all. and then everybody started running, and because there was a rupture of uterus. So if you have a loss of station, then again we are worried that where is the head going, why is it going up? And this diagnosis is obviously confirmed at emergency section or postpartum laparotomy. And even after delivery, once I remember there was a patient who had, when I was long time ago, and then she delivered a baby, she had a normal vaginal birth, and then later on she had an subtle abdominal distension. Next morning she looked very pale and she had lot of pain and pallor. And she said that I haven't passed urine for last couple of hours. And then when she was examined properly, there was lot of guarding and tenderness, and then obviously ultrasound scan and things were arranged, and actually she had developed a rupture of uterus, which was not diagnosed at the time of delivery. So these things must be kept in mind all the time, and if you have any questions and comments, you can ask me. Thank you very much.